OldGuyTalks.com is all about being a better man. Join me on this kick-ass journey. Exclusive stuff for members only in the Old Guy Cave. Opt in now. This is information only. Consult with an appropriate professional before starting any program. Do not be stupid. You are responsible for your own shit. The old guy is a capitalist and not a socialist weasel. He will be promoting stuff here and may be compensated. You can rest assured the old guy only promotes stuff he uses. You may have different results. This is Ors, the old guy from www.oldguytalks.com. Subscribe, rate, and review. And if you don't like me, well, review me too. Give me a bad review, a bad one, a really bad one. Thanks for listening to this podcast. And subscribe, rate, and review us, please. That's right. Subscribe, rate, and review us. If you like this, there's more of me at www.oldguytalks.com. Opt in there, and you'll get my 3 ways to get laid without begging. That's right, 3 ways to get laid more often without begging. This is Ors, the old guy from www.oldguytalks.com here interviewing Dr. Merrill Matschke. If you have not already opted in, do so now. Do so now. Do not wait. Do not hesitate. Do not procrastinate. And you will get my 3 ways how to get laid more often without begging. That's right. Without begging, you don't have to give up your man card, folks. That's right. So, but before we start this interview, I have to read something that Sue, the IP lawyer babe, and she knows I call her that, wants me to read. It's not the way that she would have written it, but she said it will work for this occasion. This is information only, folks, only. Consult with an appropriate professional before starting any program, any program. Do not be stupid. You are responsible for your own shit. The old guy is a capitalist and not a socialist weasel. He will be promoting stuff here and may be compensated. You can rest assured that the old guy only promotes stuff he uses. You may have different results. Probably very likely you'll have different results. So, Merrill, a little bit about your background. You went to medical school, then you did you became a certified urologist with a specialty in men's sexual health, and you're an expert in that area. And you made a transition into what type of practice you're doing. And we're going to talk also a little bit about, we're going to get into Cenegenics and some other stuff here. But just tell us about what happened to you. How'd you get on this course? Some people might say, some of your colleagues may say you have wandered off the main road.
Yeah, and, I wandered off the reservation. That's
right. And I want you to tell us a little bit about the story where the CEO of a company told you that you could be replaced.
Yeah,
that's a nice thing to hear. And also the term race to mediocrity. What do you mean by that? So tell us a little bit more about yourself and those couple of things.
Yeah, so in my previous life, I was a board certified, and I still am a board certified urologist. With a special focus in male reproductive health that really amounts to sexual dysfunction, infertility, and a lot of hormone disorders. And I started practice in Chicago about 2003. I trained at Northwestern for med school and residency. That's Northwestern University in Chicago. And then I did a fellowship down in Houston with a doctor by the name of Larry Lipschultz for my male reproductive health fellowship. And I really loved, and I still do love medicine. And as a kid, in my mind, I knew why I wanted to go into medicine. And I would say, so I was in practice, traditional practice, for about 15 years. The first 5 years, I loved it. The middle 5 years, I knew something was changing. And the last 5 years, I really was starting to suffer the typical physician burnout. There were many, many little episodes that led to, ultimately me saying, I need to change what I do, but I like medicine too much to do what a lot of physicians were doing, and that would be to exit and go to work in the industry side, whether it be for a pharmaceutical company or, other kind of industry. I wanted to stay in medicine. And I've always been interested in wellness and preventative health, really initially focusing on the men's side. And that was really born out of my fellowship that I did in Texas. I would say 2 to 3 years into my practice, I really wanted to try to expand this in the traditional model as much as I could. And that's when I ventured out to Las Vegas to do some, age management training with Cenegenics. That was my first formal kind of education and introduction into this specialty of whether you call it age management, preventative medicine, clinical wellness. I brought that back to my partners and my bigger group with the idea that I was going to try to open a men's health clinic. And I wasn't really received very well by the elders in the bigger group of urologists, which at that time were probably about 30 or 40 docs. That practice has now grown to be between 60 and 70 urologists. It's the third largest urology practice in the country.
Wow.
And, when I realized that they weren't really they weren't ready to make this step and allow someone to kind of introduce a men's health clinic the way I thought it should be, and I was the new guy. I was one of the younger partners. So I just kind of returned to my corner and started practicing medicine again, the traditional way, trying to introduce prevention as much as I could. This is a long answer to your question. So I'm just going to try.
We got time. No, I think it's a very good, very important foundation to get back.
Right. And so I really enjoyed it, but you recognize that to do it well, any medicine, and especially if you're going to try to do wellness and preventative medicine, it takes time. And with each passing year, it was really necessary to see more people per unit time to keep the lights on, pay all the bills, and pay yourself and all those things. And everyone who's a physician in traditional medicine knows exactly what I'm talking about. And anyone probably listening right now is nodding their head. Yeah, I know what he's talking about. Mm-hmm. And so what that does is it robs time from each patient encounter. And you're starting to give a product that is really more, less, it's poorer with each year because you have less time. And I was really getting frustrated. And what was happening, there are several kind of episodes, and you alluded to one of them. I would say halfway through this process, what's happening in traditional medicine, and people know this, is doctors are either being purchased by healthcare systems and becoming employed, or doctors, for the most part, then if they don't do that, they choose to join what might be called a super group or a large private practice, which is what we did.
Sure.
Well, the main hospital that I worked with, they were in the process of letting a lot of the good internists in our area that were referring to us be bought off by one of our competing hospital systems. And what happens is when a doctor who refers to you is now bought and goes to another hospital system that has their own urologist, guess what? All of what used to be referrals will now go to the new system's urologist. So we were getting frustrated because all these doctors that we had worked with that had referred us patients for many, many years were basically, they weren't fighting for them. They weren't trying to offer them the same deal that the place down the street was. So I went into the CEO of our hospital, which was in the northern suburbs of Chicago, pretty swanky area, affluent. And I said, let's just call him Tom. I said, Tom, what are you doing? You have now let 3 of the largest practices go. You haven't fought for them. You haven't offered them a deal as good as the place down the street did. And he basically looked at me and he said, I don't care, if you want to leave today, because I was probably the third person that day to come in to complain to him that we're specialists, whether it be a general surgeon, a urologist, or a gastroenterologist. All of these 3 practices held 70% of our referrals. And we all had come in and said, why aren't you trying to keep these people? And he basically looked frustrated. You could tell he was. He said, you know what, Merrill, I don't care what you do. If you want to leave, tomorrow I can replace you. It's not a big deal. If you don't like what's happening, get the hell out of here. And he used the F-bomb about 4 times. And this is a guy that I had played golf with many times in hospital golf outings. He's a really nice guy. But you could see he was now basically just a pawn for the big mothership downtown at Northwestern. And he was being told what to do, and he was frustrated. But at that moment, I realized that the situation was changing in healthcare as these big conglomerates got together, and I felt like as the doctor trying to work within the system, it was getting very difficult, and you were no longer being valued. And when he said, "Leave now, and I can replace you tomorrow," it was just a totally different game. Yeah. And then that kind of channels into this question of the race to mediocrity. Because now we're dealing with this mass market concept of medicine. And so the more medicine gets churning in this way, and you're seeing 25, 30, 35 patients in the day, it is a mediocre product. And so that the more the national system and the traditional healthcare system is moving in this direction, you're really getting mediocre care. But that's what's happening. It's just happening faster and faster and faster. So that's what I meant by the race to mediocrity. So in this final 5 years, I finally came to the point where I said, I need to do something different. First of all, personally, because in my personal life, I wanted to shift that work-life balance more to a place where it was more about my life and less about my work. I waited a little bit later in life to have kids. I've got twin boys and an amazing wife, and I wanted to be able to spend the kind of time to be a good father and a good husband. So I said, I need to do something differently. So when I come home at the end of the day, I'm not grouchy, I'm not being an asshole, and I am there for my wife and my kids. And so that was the first thing that I finally said, I got to do something different. And then I've always had this interest and passion in wellness and preventative medicine. And I had we had experiences here in the Charleston area, South Carolina, just having vacations with extended family. And I knew that one of the previous Cenegenics doctors was down here. She had left the Cenegenics group and opened her own practice. Her name was Dr. Mickey Barber. And I approached her and I introduced myself. We had some people in common from our history. And I told her what my story was, what my interests were. She realized that, I had a pretty extensive history in men's sexual health, and I was truly interested and passionate about this. So she eventually said, come work with me. So that's what led my journey here as a urologist, now transitioning into the well side of medicine, leaving the sick side of medicine, where I can now spend a lot more time with people and provide the kind of product that I feel proud of. And also, in another way, have a life that I'm proud of for my family side as well.
Yeah. We want to talk a little bit about the prostate biopsy and all that and how we lead up to it. And I will share with the audience that I had one about 5 years ago. And the result was not good. And I'll get into that a little bit later as we start talking about. I want to talk about the complications later on in the interviews. So tell us about everybody's going freaks out. There's a freak out at your PSA number.
Right.
It's hysteria. So give us your take on the PSA number and what it means and how things can affect it, and just give us a insiders or a educated, sophisticated look at that number and how it should be viewed.
It's such a complicated test and a complicated concept on how to apply it well. It is not a good screening test. That's known. I kind of think about what the recent, I don't know if it was the head of the CDC, he made a comment about the flu shot this year, saying, well, it's better than nothing, but not a whole lot better than nothing, when he was talking about, how the flu shot applied this year. And I was just thinking about it earlier today, and I could almost say the PSA is like that. And that's a little bit of an overstatement, because as a urologist who uses it, I think correctly, it is still a useful test, but it is horribly misused, not just by a lot of internists, but I think overused and overemphasized by a lot of urologists. So the PSA, for those that might not know, stands for prostate-specific antigen. Not prostate cancer antigen, but prostate-specific antigen. So it's actually, it's an enzyme that's secreted by the prostate to help liquefy the clot of semen as it comes out. That's literally the physiology of what it does. And what we realized is it can be elevated in lots of conditions that might happen with the prostate. And that's what I tell people. When they come in with an elevated PSA, they're automatically assuming they have cancer. What they don't realize, and there's a huge number of things that can cause the PSA to be elevated. An infection, having ridden a bicycle, a motorcycle, a lawnmower, a riding mower, sexual activity a day or two prior, whether that be with yourself or if you're lucky enough to have a partner with one of them. It can be due to just enlargement of the gland alone, and it can be due to cancer. But quite frequently and quite honestly, the PSA is probably a better correlate to prostate size than it is to cancer risk. And so when someone comes in who's on the edge, ready to jump off the cliff because their PSA is elevated, I tell them this before we even get into the conversation to try to calm them down. And, lots of things can throw that PSA off. So I tell people the PSA is not a perfect test. And this is another thing I tell everyone. You can have prostate cancer with a normal PSA. And conversely, you could have an elevated PSA and not have prostate cancer. So
I did not realize that about the cancer and with a normal PSA value.
Absolutely. So I tell everyone 20% of significant prostate cancer occurs with a otherwise normal PSA. And in fact, some of the most aggressive prostate cancers can actually be in the setting of a low PSA because the prostate cells have changed so much, they no longer express PSA. So it is a test that is flawed, but not worthless when used appropriately. And so you have to really sit down, and this is an individualized test and an individualized, evaluation. So if I have a guy who's just referred to me, new patient to me at a PSA of, let's say, 6.5, he's in his mid-60s, I first tell them, well, I tell them what I just explained to you, and I said, we really have to check your prostate, and then I'm going to ask him questions. Do you remember what happened around the time of that test? Are you a high, do you spend a lot of time on a bicycle? Did you think you might have masturbated, or could you have had sex the night or two before? Did you have an infection? Let me examine your prostate. It's because the size of the prostate is important as well. Now, everyone thinks when they do a prostate exam, it's all about the size. I tell guys to their face, when I do a prostate exam, I really don't care much about the size. Initially, I'm going to make note of it. But what I'm really there to do is to check the contour and the consistency of the gland, because that's where the gland will trump the number every time. Because I tell that to guys, because of that 20% number I just mentioned to you, where you can have real prostate cancer with an otherwise unremarkable PSA. So I do the exam, and if it's smooth and there's nothing worrisome about the exam, then I make note as well of the size. And I put into my mind, well, how big was that guy's gland? Because if it's a really big gland, I'm going to let that PSA creep a little bit before I'm concerned about it. And notice I said concerned. I didn't say I'm going to biopsy the guy right away. But if he comes in with an elevated PSA and he is understanding, and this is the other thing that factors in, and you have to get to know the guy and also treat his state of mind. If this is, because there are gentlemen out there who just will not be happy unless they know they don't have cancer. And in those cases, sometimes to treat the whole person, even though you say, I'm not sure that it's necessary, they say, I don't care, I need to have it. So that's where you become a doctor and you do the art of doctoring. But more often than not, as you know, guys like, I don't really want to have a biopsy. Do I have to have this biopsy? And that's with the next step. If I don't feel anything worrisome on the exam, I will then obviously look at their urine. If there's any evidence of inflammation in their urine, then that guy's going to get some anti-inflammatories, whether it be ibuprofen, Aleve, or Celebrex, something. And he's also, if there's a concern for infection, I'm obviously going to treat that infection and then repeat it. And I tell him right there, this PSA means nothing right now. We're going to treat you and repeat it. Now, if his urine is clear and I'm not worried about infection, if this were about 10 or 15 years ago, I would have given all those guys antibiotics, just because you give all those guys antibiotics and anti-inflammatories and retest. We've now learned, and we've known for a long time, but it's become very clear to me we're using way too many antibiotics. So I will only give that guy antibiotics if there's a reasonable risk that he had an infection. If I just thought it might be inflammatory, then I put him on what I call prostate rest and repeat that study. What I mean by prostate rest is no ejaculations for maybe 3 to 5 days before the test, an anti-inflammatory for about 7 to 10 days before a repeat test. No riding a bicycle, nothing that would put pressure right down there at the taint, as everyone knows what that is, what we call the perineum. Nothing that's going to cause kind of a repetitive trauma down there. Riding a bicycle, riding a motorcycle. I at the time I was right up, almost in the land of the Green Bay Packers and Harley Davidson in the northern part of Illinois, right near the border. So, Harley Davidson's, a lot of bike riding, a lot of motorcycle riding. Those are, that's vibrating and trauma to the prostate. Trauma to the prostate will make that PSA also come out. Has nothing to do with prostate cancer risk. So that's a long answer to your question, but what you have to do is you have to individualize that guy's life experience, size of his prostate, consistency of the prostate, and then use the test. And what I end up doing in most instances, if the gland felt non-suspicious, put them through that kind of provocative procedure of prostate rest, some anti-inflammatories, maybe an antibiotic was necessary, and then repeat it. And then have a further conversation. So let's say in the best case scenario, the guy with a 6.5, he comes back in and his PSA comes down into a much more reasonable range. Then I'd say, hey, let's just follow this. Now, what happens if it doesn't come down? Then you have that informed consent discussion with the gentleman. Because the other thing we now know is that, and we've always known this, but most people die with prostate cancer rather than from it. And that's a classic saying, but it is true. We are overdiagnosing and overtreating prostate cancer. Now, the urologist in me is not going to say we shouldn't pay attention to it. We need to. But you have to put it in the right frame of mind. And as a preventative medicine doctor now, and I always was, you have to look at the individual. If the guy's walking in your door and he is not otherwise healthy and he's obese, he's got some shortness of breath, he's already on a nitroglycerin issue, or he's got nitro for angina or something else like that, he doesn't have a life expectancy that puts his prostate in play. So those are the other things. You have to look at the whole individual when you're talking about prostate cancer risk and the PSA and everything else. So you can already see just from your one question of what do you do about the PSA, and I've been talking about this now for probably 10 minutes or more, it's complicated. And so there are lots of ways to handle the PSA. Unfortunately, there's still a lot of urologists out there that if that number goes above 4, everyone gets biopsied, or if they get a velocity above 0.75 of an increase per year, they automatically biopsy. I think that is unfortunate. I think it leads to over-biopsying and over-diagnosis and over-treatment of prostate cancer that may very well have never cause them a problem, and then they have to deal with the side effects. And then, I'm not going to get into the whole concept of active surveillance, which thankfully is now being utilized more and more appropriately. So you can watch a cancer and decide to intervene at a later time if it's going to show that it's going to become more aggressive. So there, just like all cancers, there's a range of prostate cancers, but more often than not, prostate cancer is fairly indolent. But if you get a biopsy eventually that shows high-grade cancer, well, then you treat it as you would a high-grade cancer. So you have to individualize your encounter with the patient, and at every step, no matter what happens, you have to individualize it. If you're going to try to apply a cookie-cutter approach, you're not practicing good medicine, which is what the race to mediocrity really comes down to.
Sure. I remember when I was told that I needed a biopsy, I was actually kind of, I resisted it for several years, and then it was kind of like, it's you got to get it, you got to get it. Before I start talking about the prostate biopsy a little bit more, can you tell us a little bit about the MRI, the Tesla MRI?
The 3T.
Right.
So for a very long time, imaging of the prostate really didn't seem to give us any extra information regarding cancer possibility, cancer risk. But with the development of very high-powered magnets, the 3T, which is Tesla, which is a stronger magnet, they've been able to get better resolution at the soft tissue level of the prostate. And they started evaluating this and found that they could find what they call regions of interest, or what we call ROIs, on this very high-powered MRI. And what that has done is now we have an imaging test which can give us another layer of information in a guy who's got an elevated PSA. Hey, does this look like there may be areas that we're worried about, or does it just look like it's BPH or inflammation? And thankfully, this is not all radiologists can read this. That's the other thing. If you're going to have this done, you want it to get in front of a radiologist that knows how to read this MRI. Urologists nowadays with MRIs, there are way too many images. And so no urologist, I don't think, is going to have the ability to read one of these. But you have to be working with a set of radiologists that do this a lot. And because the practice I was in, there were 70 of us feeding some radiologists, they got real good really fast. And it was really actually very nice. A lot of people who had maybe a previous negative biopsy, and this is where we first started using it. A guy with the previous negative biopsy, then his PSA kept going up. And we used to just keep biopsying these guys. Now we have this new tool, the 3T MRI, to say, hey, we're not going to biopsy yet, but let's send you for the MRI and let's take a look. So if that MRI would come back and say, look, it's big, there's some inflammation, we don't see any typical characteristics of what we can see on this new MRI that's suggestive of cancer, so we don't have to worry about it. That was one way it would come back. The other way it would come back is they might find some of these ROIs, or regions of interest, and then they grade those with a grading scheme. And the higher that number got, the more concerned they were that those areas might harbor cancer. And if that does, then the recommendation would be to probably go back and biopsy those areas. And at the time, you take that recent MRI image, which was done maybe a week or two before, and then you overlay it over a real-time ultrasound, so that you can use the ultrasound while you're imaging the prostate real time and have that image of the MRI overlaid over it, so you can try to put the needle into the area that looked abnormal or had a higher yield of having cancer in it within the MRI. Does that make sense to you?
Yeah. Well, having had the blind,
right,
biopsy,
you had the standard template.
Yeah. So, this brings always a question, because all of us, when we are going outside of our area of expertise, the question is, how do you assess? What kind of questions do you suggest people ask the urologist or the radiologist to determine their level of sophistication and competency? Because that, when you're walking in and you're just kind of a guy who doesn't have any particular scientific background, you're not really know the questions. And I guess I'm always worried. I guess the thing I say sometimes is, you don't know what you don't know. And that's a problem. So what do you suggest you ask, and what do you look for?
Well, what you just said is a huge problem now, because you have fewer minutes to talk to the doctor. And people really have to be self-advocating nowadays, because the doctor, he or she, is just trying to get people in and out. So unfortunately, a patient asking questions now has become more of a nuisance to a lot of people than anything else. So first and foremost, you have to be with a provider that will at least take your questions and not brush you off. And I think most people listening here now have had that experience where you ask a question and you get that look of annoyance, like, don't ask me that question. I'm here to tell you what to do. So I think the question is, first, if we're talking specifically about the prostate.
I don't want to interrupt you, but you said 30 patients in a day. That's 15 minutes.
Oh, yeah. Oh, no. You're lucky if you get 15 minutes. Okay. And so, my little explanation on the PSA there, when I gave that to patients, it took me a lot of time. And so you could already guess that, hey, guess what? Dr. Matschke was always running late. I was. But out of 70 doctors for quite a while, I was the highest rated doctor in that group. And why? Because I was taking time with people, and people aren't getting the time they want. But what to ask? I would first of all ask, are they aware of the 3T MRI, and what do they think about it? And is it appropriate for them? Okay. And then I think it's appropriate to ask them, all urologists should be asking, what are your prior PSAs? What has your previous trend been? One absolute value number of one PSA is a tiny little snapshot in time. And the utility of the PSA is more appreciated when you have a trend that you can look at. So if that doctor doesn't even ask about previous PSAs, you should get up and leave. You should ask that doctor, how much does prostate cancer work does he or she do? Because we are now in an area of super specialization quite a bit. So, these are very important questions. And, I think the most important thing is to have an open dialogue with that doctor. So that if you're going to ask a question, I think it's very reasonable. And this is the way I take it. And I wasn't this way initially. But you inform the patient as best as you can. And then if that patient is making what you think is a horrible mistake, you can't get angry with them, but you can tell them, I think you're really making a mistake, but I have done my job in educating you. Mm-hmm. So when I would spend a lot of time telling people, I think you do need a biopsy, or you know what, I don't think you do. You may have cancer, but based on what I'm looking at, I don't think you'd have the kind of cancer that we need to know about. And a lot of times I get a cross-eyed look when you say that, because people are like, what do you mean? Cancer you don't want to know about? And from my life and as a urologist, once you tell someone they have cancer, some people can't hear anything else. So if you tell someone they're going to have cancer, but you don't have to treat it, you might have just created a new problem of anxiety for that person. And so, and that's what I try to explain to them. I only want to tell you have cancer if I think it's kind of cancer that we've got to do something about. And that's almost too paternalistic for some people to hear. But I've seen it happen where people just become shells of themselves when you tell them they have cancer, but you don't need to treat it. And you recommend active surveillance, but they can't do it because their mind just won't let them. Mm-hmm. So that's you have to have a doctor that's willing to have that kind of open conversation with you. And if you're going to ask questions, they need to be at least in a state where they can listen to you. Mm-hmm. And you need to feel like you get an answer you feel comfortable with it. But asking about their experience with, what they know about the other prostate cancer tests. There's PCA3, there's 4K, there's PHI. And you need to have you need to be comfortable that person has a working knowledge with that.
Okay. Let's change the subject just a little bit, but not that much. Testosterone, PSA, testosterone cancer. I understood that from your interview with Jay, and Jay Campbell, if those of you that are listening, he has a great book on testosterone. He just came out with another one. The first one was fantastic. It was right on line with my 15 years of experience of using testosterone. And the second book is just really, really awesome on this subject. So let's talk a little bit about testosterone, PSA, and cancer. And I understand there's some new research about testosterone during and cancer.
Right. And so, for the longest time, people have always been, even physicians have always been taught that testosterone was, quote unquote, the fuel for prostate cancer. And if you actually go back to some professors at University of Chicago, they actually won a Nobel Prize for basically stating that, and it was based on one patient. Now you fast forward to current day,
wow,
and we realize that entire myth has been blown up. However, because of the way our media works and our medical system works, it's taking forever for that kind of to come into the current space of understanding. Now I'm preaching, I was sitting there with a group of people that were ready to really hear this, dating back into the 2000s. Dr. Morgenthaler was really the first one to start to unravel this. He's a urologist from Harvard. He went back to the original data of Dr. Huggins and found out that all this was based on really the data from one patient. So what is really the case? Well, let's back up. If testosterone caused prostate cancer, when are our testosterones the highest? Adolescence, right?
Right. Yep.
Puberty. So you would see an epidemic of prostate cancer during puberty when testosterones are probably 700,000, 800,000, maybe even more. So in the upper half of the normal range. But you don't. When do you see prostate cancer happening? When testosterone is the lowest. And that was something that was very interesting in one of Dr. Morgenthaler's early studies when he was biopsying a bunch of men with low testosterone. He actually found that there was a higher incidence of a positive biopsy in men with lower testosterone. So you can already see that there are so many signals out there within the data, but people aren't talking about the data. They're talking about what they were told years ago in a textbook. Another problem in modern day medicine where fear has been spread, and that's what's now been taught. Whereas no one goes back and re-challenges the data. And furthermore, no one goes back and looks at the data that's current and can apply it. It's very frustrating. So what happens to your PSA if you have a low testosterone and you correct it? And thankfully, a little shout out to Jay and Jim Brown, Jay Campbell. They are carrying the torch and really pushing the tip of the spear from the mainstream. I shouldn't say mainstream, but from a different angle. They're certainly not academic, but they're doing the grassroots level. That's what I'm trying to say. And people like Dr. Morgenthaler and others are trying to do it within the academic world, but they're swimming upstream too. So what Jay and Jim have done has been amazing. But if you take a man who's got a low T and you optimize his testosterone, your PSA will bump up a little bit. And if you understand the pathophysiology or why this happens, when you put testosterone into the system, one of three things will happen. It will either stay as testosterone, break down to estrogen, or break down to DHT. DHT is dihydrotestosterone. Dihydrotestosterone is what leads to benign growth of the prostate. That's exactly why people with a big monster prostate who can't pee take Proscar or Avodart, which has other issues, but that stops the breakdown of testosterone to DHT. So if you take a man with low testosterone and you fill up this tank with testosterone, what happens? You get more metabolites. So you're going to get more DHT. And so the prostate will actually probably increase in size a little bit. And when it increases in size a little bit, if you listen to what I said before, PSA is a correlate to prostate size. So the PSA will go up a little bit. But what you see is the PSA will go up a little bit and then plateau. So when I speak to doctors and family practice doctors about testosterone and PSA and prostate cancer, they all say, well, what do you do? How do you follow the PSA when you give someone testosterone? I said, I basically do the exact same thing, except I recognize there's going to be this bump and then a plateau. But then I follow them just like I would anyone else. It's not because they're on testosterone that you really have to follow them more closely. And I've gone as far as to say the following. They said, but aren't you worried about them getting prostate cancer? I said, no, I am as worried as I am about anyone getting prostate cancer. And they said, well, they're at higher risk, right? I said, no. But what I'll tell everyone, I said, someone who gets testosterone is going to get prostate cancer because that's just going to happen. But they were going to get prostate cancer regardless of whether I gave them testosterone or not. So there is that change in PSA that bumps up but then should plateau when you optimize testosterone. Yeah. But it is absolutely not true that testosterone causes prostate cancer. Now, I'm sure there's someone out there who's saying, well, then why the hell did they give me Lupron or cut off my testicles if I have metastatic prostate cancer? That's where there is an association with testosterone and prostate cancer. The truth is there's a threshold effect. You need a certain amount of testosterone for prostate cancer to grow. And let's say that number is around 80 to 100 nanograms per deciliter of testosterone. Once you go above that level, it doesn't matter if you have 200, 800, or 1200, the prostate cancer is not going to grow any faster. It's as if you're watering a plant. If you put more water in a plant, it doesn't grow faster, which is different than putting gas on a fire. That's this threshold effect, which is very important. Because if I have someone that comes in my office and his T is 350, they're like, well, you can't give him testosterone. You're going to cause prostate cancer. I said, you don't understand. And then I have to have this conversation. But I'm still beaten upstream to everything anyone can find on Dr. Google about testosterone and prostate cancer. Yeah. So, at some point you beat yourself against a wall and you get exhausted and you say, you do what you want. I'm here to help you. And you either want to listen to me or not. And, men will usually, listen if they're so interested. But now there's a lot of interesting studies where they're actually using testosterone. And these are very, very preliminary. But testosterone is being actually used in some advanced cases of prostate cancer. And we're starting to recognize that estrogen has actually more of an effect at the cellular tissue level with cancer in the prostate than they ever knew before. So as you start peeling back the layer of the onion, you start realizing there's a lot more complexity. And we're starting to realize the genetic individuality of people and the genetic polymorphisms are as important as anything else. And we've known that in cancer and breast cancer for a long time, but they're starting to really embrace that knowledge and really tailor cancer treatments based on what we know about genomics now too. So the whole story of testosterone and prostate cancer was totally misinterpreted, and we're in the process of unraveling that and trying to repackage the information so that people know the following. And this is what I tell to everyone. In the United States this last year, somewhere between, I don't know the exact number, but let's say somewhere between 25,000 and 30,000 men died of prostate cancer. Yes, men die of prostate cancer. I've had several patients die of it, so it can kill people. But how many people died of cardiovascular disease? How many men? Probably closer to 1 million maybe 750,000 to 1 million men died of cardiovascular disease. What's one of the huge promoters of cardiovascular inflammation? Low testosterone. So we're focusing all this time on prostate cancer and really not paying attention to the impact of low testosterone and how that's really a bigger risk factor. So, what you have to do is prioritize what's happening in the man and treat that man accordingly.
Okay. So, actually, I want to give a shout out here to my anti-aging doc. I guess you call them functional medicine doctors now. At least I heard that's the new term. So if you are in the Phoenix metropolitan area, close by Ramon Escuerdo, you can see
I see his picture right there.
Yeah, he's right there. He's on the call. And
I saw what he said about prostatitis. He's absolutely right.
Yeah. So yeah, we kind of covered that a little bit earlier in terms of that. Actually, we went into great detail in about the PSA earlier. But Ramon is a great doctor, very forward-thinking, very knowledgeable, and can guide you through this jungle. So if you want to reach out to him, I don't know if you want to put your office number, Ramon, in the content and in the comments section, please do. Yeah, he's very, very forward-thinking and an expert in this area. So let's switch to the actual prostate biopsy. In 2018, any techniques better than others? And when the decision is made to do a biopsy, what's the best process today?
Well, one of the things we know is a concern with the prostate biopsy is a risk for infection and sepsis. And there has been an increase in sepsis. I'm talking about the kind of sepsis that will put someone in the intensive care unit and possibly kill them. Now, it's not a huge risk, but it is a real risk, and I've seen it happen. So what really should be happening, and our practice was one of the first in the United States to do this, we would do a rectal swab on everyone before they got the biopsy so we could exactly identify the flora in the rectum. Because there were protocols, whether someone got Cipro or Levaquin or something else before the biopsy. We started to realize, though, as I just mentioned earlier, overuse of antibiotics, we've developed a lot of resistant organisms. So you really need to know, if you need to do a biopsy, you want to know exactly what's growing on that guy so you can appropriately prophylax him. And that will minimize the risk. And we saw it dramatically in our bigger practice. We literally, I think we took our sepsis or infection rate afterwards was somewhere in the standard 3 to 5%, or maybe even a little bit lower. But after we did this, we were below 1%. So you need to make sure that you're dealing with a practice that is doing rectal biopsies beforehand and not just giving you a shotgun guess of the antibiotics. Because the risk of and the rate of resistance is going up. In terms of types of biopsies, I mean, still the standard in this day for most first-time biopsies is the standard transrectal ultrasound biopsy, usually with 10 to 12 to 14 biopsies, depending on the size of the gland, and that's in a standard template like you had. One of the reasons not everyone's getting the 3T MRI at this point, guess what? Insurance coverage. So a lot of insurance companies are not covering the MR fusion biopsy, as it's called, unless the man's already had at least 1 or 2 prior negative biopsies and his PSA is going up. Now, this is a dynamic situation, and as I was leaving my practice in Chicago at the end of the year, there were some insurance companies that were starting to incorporate, more coverage for that test, but it still wasn't being done regularly. I think in the years to come, you're going to start seeing these are already in development, but smaller versions of MRIs that are going to come into patients' doctors' offices and be sitting there instead of the ultrasound. So that ultrasound technology or MRI technology is just, as everything else, is getting so much better so rapidly. We're soon going to have that in a smaller platform where we can actually do an MR guided biopsy in the office. But that's certainly a couple years away at least. But the device is actually being developed as we speak. Those are I think at this point, that's where we are still. But the question is, first and foremost, do you need the biopsy? And as I said, I was not against some guys. I had guys, believe it or not, with PSAs in the teens who I hadn't biopsied because by the time they came to me, they had been there for years, and I was looking at their trend more than the absolute value of the number. And most of these guys had a real big prostate, or they had had a previous history, just as Dr. Esquerdo had talked about, of prostatitis. Some of these guys, once they have prostatitis, I tell them your prostate's permanently tweaked, which means you look at it cross-eyed and the PSA goes up. He was absolutely right to bring up prostatitis, because if you get a PSA that goes from 2 to 50 in 6 months, some guys come in and say, oh my God, I've got horrible cancer. That's never cancer. That's always inflammation. It can't go up that high. It's almost always due to inflammation. Again, I kind of veered off your topic there, but
that's very good. That's very good.
But it's really still a transrectal biopsy, as most people will get out of the gates. But we can do better on our prophylaxis with the rectal swab prior.
Yeah. You just explained something to me, which leaves me even more pissed off about my biopsy, because we're going to get into this complications stuff. When I had my biopsy 5 years ago, there were, if I remember correctly, somewhere between 30 to 36 samples taken.
So you had like a saturation type biopsy.
I had, yes, and a normal size prostate, a few numbers off here and there, but that's where I was. Wow. And the end result was, and I shared this with everyone, the end result was my sexual function, my orgasm, was incredibly diminished to about a third of what it was before, like instantaneously. The next time I had sex with my wife, it was immediately evident. She looks at me and she goes like, what happened? And I go like, I don't know. And so it was an immediate, it wasn't like gradual, like from aging or anything, but it was an immediate decreased performance in that area, and it's never recovered. So I think that there's a little bit of dishonesty, not a little bit, a lot, because people are told when they go in for a biopsy, oh, you'll be just as fine as you were before. And I went back to my primary care doctor, and I was talking to his PA, and she goes, oh yeah, we hear that a lot. I'm going, fuck. And that's what I mean. I was like, I'm thinking about, I said, really? And no one tells you that? They tell you, oh, you're going to be just fine. You're going to be fine when you get 30 to 36 core samples taken. So, yeah, I'm definitely pissed off. So for the last 5 years, off and on, I've been on kind of a quest to see what can I do to improve the functioning of my prostate from a sexual standpoint. So what options are out there for men that have had their prostates damaged during a biopsy?
Yeah, and it's certainly not the common side effect, but I too have heard it. You are not, some crazy man out there by yourself. I have heard people mention that.
Well, I am crazy sometimes.
Yeah, well, of course, we all got a little bit of that in us. It's interesting when you tell me how many biopsies you had, because that's atypical for a first-time biopsy. Prior to the MR biopsy, there is something called a saturation biopsy that we would do a little bit differently, where they would do up to 60, 70 cores. But in a case like yours, I think it's fair to say, and it's totally logical, the more cores you have, the more inflammation you're going to have. And then inflammation, we know, all over the body leads to badness. And so I think you probably had either a combination of scarring in the level of the ejaculatory ducts. You oftentimes get some biopsies of what's called the seminal vesicles, which is where a huge amount of the volume of the ejaculate comes from. The musculature around that area is involved with peristalsis, which basically pushes that ejaculatory volume into the urethra. All that area gets inflamed and irritated. So the more biopsies you have, the more likely you can have some kind of inflammatory change and scarring. And the fact that you know that it happened that first time afterwards, I don't care what someone's going to say. Oh, that can't be that couldn't have happened. You're living it, and 100% of the time it happened to you. Right. So if someone tells you, well, that might only happen less than 1% of the time, well, if you're that one guy, it's 100% to you. And so and in those cases, if it does happen, you hope that the standard answer. Well, let's see if it gets better with time. So if there's been some type of damage to nerves or to the musculature that involves, so much of what we as men experience as an orgasm is having to do with the rhythmic contractions of those pelvic muscles that surround the urethra. And if those have been permanently damaged, sometimes there's not a whole lot that you could do. Now, there are drugs. Obviously, if someone came to me with this, I'd first see what your T is. If your T is low, I'm going to turn up your testosterone. I'm going to replace it because that could be related to, decreased overall satisfaction with the intensity of orgasm. I'm going to also, take a look. I'm going to ask you questions about, what happened to your ejaculatory volume. Could you have some kind of obstruction of the ejaculatory duct? Now, there are off-label kind of interesting things to look at. Oxytocin is a big hormone related to kind of the experience and the pleasure of orgasm. You can actually replace oxytocin before sex. See, if that helps. You had mentioned previously some experience with PRP, or stem cells. Could that be an option in the future? I think regenerative medicine and some of these topics of stem cells and using growth factors, putting them in places, whether, anywhere, to help healing and perhaps regeneration of scarred and inflamed tissue is another good option. But I'll tell you right now, there aren't a lot of good options, and you're living that, and that. It's frustrating. And I'm assuming you're adequately replaced on your testosterone. Those types of things.
We've got that dialed in nicely.
And I mean, I don't want to dig too much into what else is happening, but this is not a rigidity issue for you. It is primarily a intensity of the experience issue. Correct? Yeah. Well, and people might not realize this, but when you have an orgasm, literally the fluid that's being pushed out and the musculature that's doing that really is what's causing a lot of that intensity of the experience. So if you have had damage to that tissue, you're going to have scarring, and that's going to be less so. Now, you could do biofeedback. You can do pelvic floor physical therapy. You can do, there's literally physical therapy for this area where you can strengthen those muscles, kind of a type of Kegel exercise, if you will, to try to strengthen those. And that's always been a side benefit to people doing Kegel exercises. You're exercising those muscles, and as they get stronger, then when you have that orgasm, they're stronger muscles, so you have a more intense experience. So that's certainly another thing that one could do.
Okay, great. Any supplements that help or anything like that, or is it just kind of trial and error?
And I'm blanking on the supplement that people always talked about the porn stars taking for larger ejaculate volumes and things like that. And maybe Dr. Esquerdo can remember it. I am not aware of any really good science or studies that show that there's going to be a supplement that's going to really help there. There are all these different herbs that are available that people will tell you will have some effect, but I have not been that impressed with those.
Okay. All right. So, we're going to have you on. We're running up, kind of cover this subject, I think, pretty well at this point. I'd like to have you back here in a couple of months. We want to talk about the low sperm counts that are occurring due to toxins in our environment, things like that, and the effect that it has on basically population and basically procreation. I want to talk to you because your some of your stuff was very, very interesting on that whole subject. So if somebody wants to get a hold of you, do you do any telemedicine?
You know, we're trying to do telemedicine, but with the legal environment right now, it's not really conducive. Dr. Barber was actually trying to do that for some, Louisiana, a couple other states close by, and it just really hasn't materialized yet. What are the way I work at Better Life Carolinas in Charleston. We also have an office in North Carolina, Charlotte, North Carolina. And a lot of our patients are from, far away. A lot of them are not local. We just have to see someone for the most part once a year. And much of our follow-up is done with phone calls, emails, texts. So it's not technically telemedicine, but it's virtually the same thing. But, Charleston or Charlotte are nice places to visit, great food. Charleston is, right on the water, so it's not bad to come to once a year. But you can get a hold of me at Dr. Matschke. That's DrMatschke at betterlifecarolinas.com. You can also just go to the website betterlifecarolinas.com and find us too. That I see what Dr. Squerto mentioned there, and I'm sorry if I'm killing your name, but Deer Antler I have heard, and that's the other thing. People should try things unless it's going to kill your wallet and do too much what I call a wallet biopsy on you. If I get tired when people talk about a placebo effect, because just like I said before, if you're that 1% that has a side effect, it's 100% to you. If you take something and you got a positive response to it, I don't care if it's a placebo or not. It treated whatever your problem was, right?
Yeah, who cares?
I do know that a lot of those ED things you're going to buy at a gas station aren't going to work for you. I can tell you that much. But there are people that have tried, certain things, whether it be as simple as DHEA or Deer Antler or something else like that, and they have a positive experience. So, as long as we know it's not doing something bad, I have no problem with that.
All right. So the old guy is all about virtues and vices. And tonight, one of my vices is a Gurkha evil cigar. Gurkha is one of my favorite cigars to smoke. It usually has a pretty smooth smoke, and the evil though is a little bit heavier than the rest of the Gurkhas, but still a good cigar. So I'd like to discuss my guest's vices.
Interesting.
At the end of the interview. So that's usually your reaction is pretty much the typical reaction I get from my guests. So like they're wondering, where is this going? So let me start off. Actually, the first question here, my wife just gave me a new question, which is fairly easy. Easy. If you were to compete in an Olympic event, either summer or winter, what would it be?
Well, I would tell you what I'd like it to be, because I used to actually race sailboats. So I would probably try to get into one of the sailing events in the summer. Okay. Or I tell you right now, I've always been a huge snow ski fan. I wish I was better. I wouldn't mind to do the downhill if I had the guts. So there's one winter games and one summer game right there.
Okay. All right. So what kind of music do you listen to?
If you would have asked me that before I met my wife, I was kind of the classic rock or the Dave Matthews Band. And then I liked, for some reason, way back when I've always have been a big fan of Simon and Garfunkel and the Doors and the Who. Never really liked rap or any hip hop that much. And then I met my wife, who's 12 years younger, and now I'm just about open to anything except really heavy metal. She introduced me to a little bit younger, more youthful medicine. So that right now, just about anything except really heavy metal.
Okay. So if you are in the closet and the door is shut and you're hiding, what are you eating that's bad?
Cheez-Its.
Cheez-Its?
Yeah. Cheez-Its or Nutter Butters.
Okay. All right. And how often do you do that? Come on. Spill the beans.
Well, I came out of not often. It's interesting because I lost 40 pounds in the last 2 years. I gave up alcohol about 9 months ago. Yeah, I know.
Oh my God.
It was on my quest to lose my my love handles, which took me a long time. They were gifts from my father that keep on giving.
Yeah.
So that's when you said, "What are your vices?" It's kind of boring now. It's I don't really have a whole lot of vices, except I will allow myself to have some chocolate. I will allow myself to have a nice pizza with my wife and some ice cream, because she's a huge lover of pizza. So those are. I sound really boring, but put it this way: I had a long life before with a lot of not boring, and so I've done enough probably for my whole life up to this point, and I've decided to kind of clean it up.
Yeah.
Does that make sense?
Oh yeah. Yeah. Well, when I was 45. Actually, that means I've been on. That's when I went on testosterone. My waist and my age were the same, and
Gotcha.
and I was keeping pace. I was keeping pace in both areas. So that made a real big difference in terms of leaning out my body and putting on a lot more muscle mass and things like that. So you don't drink alcohol. We gotta get you smoking cigars, dude.
Yeah, I wouldn't be against that, but I'm not certainly a frequent smoker of it. What's interesting is I meet people like Jay, and a lot of people that I've met as I've come into this new space. I'm meeting a lot of people who just decided they're not drinking anymore, and basically because of the health benefits.
Yeah.
And then if you go back and you go into traditional medicine, those are the guys that are still drinking a lot.
That's because they got to see so many patients in a day.
There's that's a whole nother time, a whole nother hour-long talk. But yes, it is.
Yeah,
exactly.
Yeah. So what would someone be surprised to find out about you? What deep, dark secret can you share with us here on the internet?
That's a great question. I know I'm trying to, when your mind goes blank.
I know. Make something up.
I got to come up with something good. Well, I don't know if it's a deep, dark secret, but I met my wife in Las Vegas at the Wynn Hotel, and my first child is named Wynn.
Oh my gosh. That is a beautiful hotel.
Yeah, it really is. And I probably shouldn't say that in today's world with what Steve Wynn is now apparently involved with. But, life goes on, and you can't look in the rearview mirror.
That's right. So, folks, I think that pretty much wraps it up. We got through the vices, none too many. We're going to have to get Merrill on some cigars at least once a week. It's not going to kill you. You don't have to be such a Boy Scout like Jay is. I mean,
right.
that man's an animal. He's incredible. It's like I look at that and I go, oh, I don't have that level of willpower that he has. But he certainly is a shining beacon about what you can do with your body and your mind, and how to optimize your hormone levels and a whole bunch of other things. So, Merrill, I want to thank you for coming on the program. It's been a great pleasure. I look forward to having you back on, because we're going to talk about that. We're going to talk about that subject about low sperm counts and your diet and everything else at another time. So, folks, this is Urs, the old guy from www.oldguytalks.com signing off. Remember, opt in, and you're going to get my 3 ways how to get laid more frequently without begging. That's right.
I need that.
Begging. You opt in. You can, and they're really simple. It's very simple how to do that, and you can get those, and you can implement them right away. Some of them are going to confuse your wife or your girlfriend or whoever that special person is in your life. Hopefully they're the same person. They're very easy to implement on a daily basis, and you will be appreciated. I think you know what I mean when I say the word appreciated. So this is Urs, the old guy from www.oldguytalks signing off. And remember, it's all about creating a kick-ass life. That's right, kick-ass life. Take care. Opt in and encourage other old guy assholes like you to opt in also.